Kalamazoo County Colorectal Cancer Awareness Network, or CRAN, was formed in 2007 by a network of diverse community members with the common goal to reduce the burden of colorectal cancer among the citizens of Kalamazoo County by raising awareness among its citizens.
My name is Ann Menke. I'm the Health Initiatives Coordinator for the American Cancer Society. March is Colorectal Cancer Awareness Month, and so we are gathered here to help educate the public about this disease. Colon cancer is the third most commonly diagnosed cancer among men and women. It's also the third leading cause of cancer death among men and women. It's estimated that in the year 2012, one person will be diagnosed every 4 minutes in the United States with colon cancer. That's 14 per day right here in Michigan. However, this cancer is preventable, it's treatable, and it's beatable. There are certain simple steps you can take to help reduce your risk of colon cancer. First of all, if you're 50 years or older, a screening test can save your life. Be sure to talk to your doctor about what screening test is right for you. Some tests, like a colonoscopy, can find a polyp and remove it before it ever becomes cancerous. It's also very important to know your family history. If you have a parent, a brother, a sister, or a child who've been diagnosed with colon cancer, screening can be even more important. Be sure to talk with your doctor about your family history and about what test is right for you. There are also several other things you can do to help prevent your risk of colon cancer. Maintain a healthy weight, remain physically active, be sure to eat a healthy diet, limit alcohol consumption, and avoid tobacco use entirely. You have the power to prevent colon cancer. Screenings can help doctors tell whether there is a problem, and some tests, like a colonoscopy, can remove a polyp before it ever becomes a cancer. Now, we know there's a lot of fear and anxiety around colon cancer screening, but there doesn't have to be. That's why we're here today, to eliminate a little bit of that fear with information. We're going now to Andy Reeves with the KCMS Pharmacy to walk through the prep for colonoscopy, and later we'll see a live procedure.
Hi, I'm Andy Reeves with KCMS Pharmacy. I'm a pharmacist, and I'm here today to talk to you about the different colonoscopy prep kits that are available. Colonoscopy prep kits is probably one of the most important aspects of preparing for a colonoscopy. Improper preparation or use of a prep kit and the dietary restrictions prior to a colonoscopy is probably one of the leading causes patients have to redo a colonoscopy, or that doctors do not get good enough results because they cannot properly see the colon. The most common kit that's used for colonoscopy is the Miralax kit. And it's an economical kit, and it's probably one of the more palatable ones for taste-wise and patient acceptance. It's kind of virtually tasteless powder, and patients usually mix it with Gatorade, and it usually comes with two 32-ounce bottles of Gatorade, and half the bottle, which is 17 capfuls, goes in each of the Gatorade bottles. Then it's usually refrigerated, and patients usually take one bottle at one time and the other. And the other thing with the Miralax kit is it usually comes with 2 to 4 Ducalax or bisacodyl tablets, which are taken the night before. And as you can see, it kind of comes with the instruction page from the office. The next product is called Half-Lightly. This product is used for special patient populations who are intolerant or have to have requirements of phosphate, because phosphate is one of the salt components that is used in a lot of these kits. So this is used for patients who cannot intake a lot of phosphate, such as patients with kidney disease. The Half-Lightly comes with flavor packets that can be added, and as you can see in the bottle here, there is some powder. It is filled with water to the line, and the instructions have the patients drink so many glasses over a certain period of time. And that can vary based on the doctors. There's usually manufacturer recommended directions, but physicians often vary them and add different things to them based on that. So it's important to have your physician's directions for the use of the colonoscopy. This kit also comes with the Ducalax or bisacodyl tablet that is often taken the evening before starting the liquid. And that is kind of just a stimulant laxative to get the intestinal activity moving. Another very important aspect of preparing for the colonoscopy is following the clear liquid diet before the day before. And that consists of drinking only clear liquids and fluids and avoiding anything that contains red or purple dyes, because that can still remain in the intestinal area, and the red can be confused with blood. So you want to avoid anything that's red or purple dyes in it. And so clear liquid diets, you can have coffee, tea, you can have Jell-O, you can have broths, but when you have coffee and tea, there's no dairy products or creamers that go with that. And you can have all the soda pop or water that you would like. So the key is to stay hydrated and drink lots of fluids with these kits. Another important aspect of when preparing for your colonoscopy is to talk with your pharmacist about the directions of your colonoscopy and your kit. It's very important you understand those directions, the dietary requirements that start beforehand. Some of them start 5 days before with restrictions on nuts, and there's certain medications that are restricted that should be stopped prior to up to a week before your colonoscopy. And working with a pharmacist who's familiar with your physician's office's directions and kit preparations is important.
Hi, what can I do for you today?
I'm here for a colonoscopy with Dr. Durso.
And do you have your insurance card with you
I
today?
do.
Looks like we already gave you a call, got you all pre-registered.
Yes. And why did I have to go through this with having been called?
I'm going to check you in. Just make sure we heard your insurance information correctly, and now I'll have you sign a consent and you'll be all set. We
Okay.
already verified the bulk of your information
Oh,
today.
good. So I don't have to give that all over again.
No, we're all set. Okay, looks like your insurance is all set. Now your pager's going to light up and flash red. When it does, you're going to go right through testing door B.
Okay.
Your appointment time is in 1 hour. If they don't call you in 15 minutes, please let me know.
Thank you.
You're welcome. Have a great day.
Thank you.
And your name? Marcia. Hi there, Marcia. Welcome. I'm Cindy. Come on this way.
We've got you scheduled with Dr. Durso for a colonoscopy, is that correct?
Yes.
Okay, we're going to have you get your gown on first. You can put your belongings in the closet there. Now, do you have any valuables with you?
No, I left them with my ride
Okay.
because I didn't want to worry about them.
Okay, that's good. Well, we need everything off except bra and socks. The ties will go in the back on the gown. Bathroom is there if you need to use it.
Oh, good, because I could use that right
Yep.
now.
Just remember to lock the other door that's in there and unlock it when you're done. And I'm going to pull the curtain, just open up when you're done, and we'll be back and go over some things with you.
Okay, thank you.
Now, last time you had any solid food to eat, like toast, eggs,
Wednesday evening,
okay? And last time for liquids.
9:30 this morning. I'm going to be out for this, aren't I?
We don't like to say you're going to be completely out. We want to make you comfortable. A lot of times patients do not remember. And this medicine that we use works very well. We'll have an anesthesiologist that will be coming in to talk to you about the medicines that we give to you. So, and who is going to be your ride home today?
Nick, a friend.
And do we need to call him? Is he here?
He'll be here when I'm ready to go.
Okay, and what is his number? Just in case we need to. Okay. And about what time was he going to be back?
He'll be here about 3.
Okay. Medicines. That's our next.
Oh, I brought
Do
my
you have a
medicine
list?
record, and I put my dosages and how often I took.
That is
take 'em.
great. That's very important to have a list of medicines and the dosage, when you take them, why you take them, and that does help us. What will happen here, the anesthesiologist will come in and talk to you about the medicines we give to you. We will be starting an IV, and that's how you get your sedation. And I'm not sure who's on today, but he'll be in to talk to you about that if you have any questions in regards to that. We will start an IV here, but you don't get any of that medicine until after you talk to Dr. Durso. Once they're ready for you, we take you on this cart. You stay on this cart the whole time. We'll take you down the hallway to the lab where the procedure's done. You'll be able to talk to Dr. Durso before you get your medicine. We do put you on a heart monitor and oxygen. That goes hand in hand because of the sedation that we use. Once the procedure is done, you'll come back to this room to recover. We keep you up to an hour, but we're finding with the propofol, if you do receive that patients are waking up sooner and get to go home sooner. And then once you start waking up, we'll have different juices and crackers for you. Now, I do want to go over do's and don'ts for the rest of the day. I know you've been through that, but we still like to go over those. Okay. You will get a copy of this when you're discharged. It'll be filled out by Dr. Durso, okay. But we like to review these. Tomorrow you can get back to normal, but for the rest of the day, no driving, no alcoholic beverages. Don't want you making important decisions. Don't want you working with sharp objects or power tools. Don't want you responsible for children until fully alert. No working today. And you should be observed cancer by a responsible adult till you're fully alert. So we just want you to be lazy.
I wonder if my ride can't get here. I have my car here because I had to drive in, and we're going to take
No,
it.
there is no driving at all today because of the medicine, because it can alter your reflexes and that. So
Can I go home in a cab maybe if he can't make
only if you have someone with you. And then these are symptoms you may experience because of the medicine we give to you today. Dizziness, lightheadedness, vomiting, dry mouth, drowsiness, hiccups, nausea, headache, and forgetfulness. Okay? But you'll get a copy of this so you don't have to have that memorized. But this gives Dr. Gerso permission to do a colonoscopy with possible biopsy, polypectomy. What that means is she'll go through the whole large bowel, which is about 4 to 5 feet. Biopsy is if she sees any tissue she feels she needs to take a sample if she can. Any polyps, she'll remove them. So we'll have you take a look at this.
Okay.
We'll start your IV after the anesthesiologist talks to you, and then we'll get you going.
Okay.
Do you have any questions that you can think of?
No, I really thought the prep was going to be a lot worse than it was, but
Okay, that usually is the worst, the prep and
but
procedures.
it wasn't that bad.
Okay.
The pharmacist was really good about telling me to make sure that I took it and to drink everything, no matter what my results were, to drink the whole prep, and I did do that. So I hope I'm cleaned out well.
Good.
Because I know you can't see the colon very well if it's not cleaned out.
That's correct. Correct. And we'd like to get this over once. And
Yeah,
not
I don't want to have to come back tomorrow.
So I will go give Nick a call, and we'll be back after anesthesia's in to talk to you and get your IV going.
Okay.
Hello, Ms. Cairns.
Hi.
I'm Dr. Atkinson. I'm the anesthesiologist today.
Nice to meet you.
I need to ask you a few questions so we can take good care of you today.
Okay.
So what we do for this kind of procedure is we give you IV sedation. We give you medicine to make you very sleepy so that you're not aware of what's going on during your procedure.
I don't want to know anything going on.
Okay, well that's our goal. With sedation like this, it is possible to remember, but it would be very unlikely.
Okay.
And if you do remember, details will be very, very foggy. We're going to do everything we can to keep you safe and keep you comfortable. There are always some risks with any anesthetic. It's possible to have complications, but it's very rare to have serious problems. With your good health, I expect you to do just fine today. We will do our best to make sure that you're safe and comfortable.
Good.
There will be 2 of us taking care of you, a nurse anesthetist and myself, and at least one of us will be with you at all times.
Okay.
Okay.
Thank you so much.
Thank you very much.
Hi, Dr. Gerso.
How are you?
I'm good.
Masha.
The prep was interesting.
Had you ever done it that way?
I hadn't, but it worked out good, I think. I hope I'm cleaned out. Because I know you got to have a good prep to see the colon.
Definitely. All the way.
But, oh my goodness.
It didn't cramp you up too much?
No, I'm just very thirsty.
Yeah. Well, I'm Nancy.
Hi.
And I need for you to tell me your name and birth date.
Marcia Cairns, C-A-I-R-N-S, 8/12/49.
And are you allergic to any medication?
I am morphine, codeine, Vioxx, and sulfa.
Should I review briefly what I'm going to do?
Please.
Okay, so we're going to have you nice and sleepy. I'm going to insert the instrument all the way, rectum to cecum, 5 feet, and look for polyps. And if I see polyps, I'm going to take them out today, unless they're too big.
Okay.
And if
What happens if they're too big?
Then I would typically leave a little ink in the lining and tattoo the lining such that we can ask a surgeon to help us laparoscopically at a later date.
Okay.
And then we would biopsy the polyp and have that information for the surgeon.
And what causes polyps?
Well, at your age, there would be a concern about genetic predisposition. Patients who are in their 40s, 50s, and 60s developing cancer at that age. And you do have a family history.
My father died of colon cancer.
Yeah. Now, how old was he when he had
He
that?
was about, excuse me, 62.
So he was quite young.
And then he had surgery, and they thought they got it all, and then about 5 years later it was back, and they gave him about 6 months to live. But this was about 35 years ago, and I know that the treatment modalities are a lot different then, and they didn't do screenings, I don't think, too much at that time. And
Right.
so that's why I feel it's so imperative that I get in for a good
Oh, yes.
screening.
You would want to have exams every 5 years with that history. Now, as we age, we're all more prone to polyps and then colon cancer. And so the older you get, the more
And
environmental factors
older
play.
than dirt, so. I never thought I'd be this old. But I'm glad for the alternative.
Yes,
you know,
definitely.
So, but,
Okay. So after the procedure, I'll review what we found and what
Okay.
needs to be done and how we're going to follow you up and then take it from there.
why am I on my left side?
Oh, primarily because we don't want you to aspirate if you had a little bit of choking, and also so I can travel through your sigmoid colon easier.
Okay.
Mm-hmm.
All right.
And you also breathe better on your side, usually, if you are prone to snoring or a little bit of obstructed sleep. Got it. I can see you're getting sleepy, so Nancy, if you could just dim the lights a little bit. We do a quick rectal exam. Just to make sure we don't have any surprises. And use the air to inflate the colon. Gives us a chance to see the path. And this is when we realize how important a good bowel prep is. You can see clearly where we're going. The detailed inspection is on the way out, but we certainly pay attention to any abnormalities on the way in. And I have a fiber optic tube that is bendable and steerable, so it will follow the curves of the colon. If the patient were awake for this, she'd probably feel a little crampy as we go along between the air and the pressure from the scope. But with a propofol, she does not feel any of this. Hopefully having some good dreams, Jeff.
I think so.
Yeah, patients receiving propofol usually tell us they have really nice naps. And the other thing we like to do, if possible, to get a really good view of the colon is to look in a backwards view. We could do that by making a U-turn. And we are now looking back at ourselves towards the right rib cage, and it allows us to look at both sides of the valves. In case we miss something in a forward view, we can see it in the rectoflex view. And maybe that will increase the sensitivity of polyps or tumors in the right colon. So now we're slowly going to come back out. We're in no rush. We want to screen behind every little crevice and fold. Since the GI tract isn't sleeping, it will keep producing secretions and liquid that comes downstream. That's a little suction pithy. And so it wouldn't be unusual to see a little bile like this. There's been a lot of talk about flat polyps, and they can be easy to miss unless you really have a clear lining and take your time looking. Polyp could also look like a mushroom or a bump or a mole, a pale mole. And we have not seen any polyps yet. So I keep air in enough to distend it and see well, and yet try to pull out a little air as I go, so she won't feel too uncomfortable or gassy following the procedure. And yet she will have some to expel, and we encourage patients to do so after the procedure. Otherwise, we can be a little crampy. And that process usually doesn't take more than half an hour to an hour. So usually the procedure takes about 18, 20 minutes from beginning to start, from beginning to finish. It can vary a little bit depending on how tortuous it is and how good the prep is and how well the patient's doing, but the average time is about 18 minutes. So it looks like Masha is going to celebrate this weekend. And because of her family history, she will be invited back in 5 years. That's what the guidelines suggest with her family history, every 5 years. She has not had polyps in the past. And then the guidelines suggest that one can likely stop screening unless there are unusual circumstances at age 75. That's a diverticulum we see there. It looks like a dimple. And she has a few of those in her sigmoid colon. Very, very common. Usually does not cause problems. Occasionally it can cause attacks of swelling and pain, and that deserves immediate attention. There's another one. There's a minuscule little bump there, and I think we'll take that out, Nancy. It has the appearance as if it could be a small, just a regular forceps would be good. And in the sigmoid here, you can tell it's a little tortuous. And it does not look worrisome at all. It's minuscule. Probably about 2-3 millimeters. So we're using a forceps that looks a lot like a tweezer as it comes out on the screen. She will not feel that. Even if she were awake, she wouldn't feel that. And just this little tiny open, close. Let's see if that's enough. Let's just see. Perfect. Good. We'll call that sigmoid. Now, when polyps are that small, we can actually not tell if they're true polyps or just a little bump in the road called hyperplastic polyp. So we send them off, and the pathologist will tell us. A little polyp like that will not have any chance of having any cancer cells in it. And last final look, and we'll be done. Okay, that's it. She did great.
Oh. Okay, and now we're gonna sit you up, and we're gonna interview you. What's today?
It is Friday.
It's Friday.
TGA Friday.
She's awake. About 4 minutes after the procedure finished, she's wide awake. Almost wide awake. And she'll sit here, Nancy, for maybe a half an hour, 45 minutes, and then she'll go home.
Okay. How do you feel, Marcia?
I'm very good. I do not remember a thing. It was very good.
That's right. Are you comfortable? Are you having any discomfort at all?
Not at all.
Okay, great.
Yeah.
Are you thirsty?
I am incredibly thirsty. I'd like some water, please.
Just water, or do you want some juice or
no,
Sun
water
Up?
would be great. Okay.
I did find a little polyp the size about 2-3 millimeters.
Is that tiny or?
It's very tiny.
Okay.
And I took that out.
Okay.
And it could be an adenoma, a benign polyp, but it might also be a hyperplastic polyp. We'll see.
Okay. Now, what's that? What's the difference?
The difference is that adenomas tend to grow in eventually has the potential of becoming a cancer. The hyperplastic polyp we don't worry about.
And what happens? It goes somewhere to get examined?
Go to pathology, and I should have that back next week, and then we just call you about the result.
Okay.
Since it's so small, that will not influence your surveillance. I think it's okay to go 5 years till next time.
So I didn't have any cancer or tumors?
No.
Oh, good.
Isn't that great? You can celebrate. So have a great afternoon.
Thank you.
And we'll see you next week.
All right. Thank you so
You're
much. I
welcome.
appreciate your help.
We hope you found this information valuable and that it inspires you or someone you love to be screened for colon cancer. If you have any questions or need any more information, please have a conversation with your physician, or you can call the American Cancer Society anytime, day or night, at 1-800-227-2345.